We did the functional examination, but now the question is, how can you interpret this examination? Well, let me give you some highlights. First of all, I would like to emphasize, please avoid useless testing. What do I mean by that? In our profession, there's a kind of overconsumption of a series of tests. Yeah? If you look at different books on orthopedic medicine, manual therapy in general, you find a huge number of all kind of manual testing, but we have to realize that the absolute majority of those tests have a very poor validity. So if they have a very poor validity, then you can ask yourself the question, why do you perform them? Yeah? And certainly many tests which are based on your fingers, manual palpation, be careful with those tests. No? Or be careful with the conclusion you draw from those tests. So we're going to try to have a relevant, compact functional examination. And as always, we're going to focus on a cluster of positive tests, a cluster on negative tests. We look for patterns. We don't look for single positive tests. We really look for patterns. That's really important. Well, remember lumbar spine? We talked about full articular pattern, partial articular pattern. What is the full articular pattern in the cervical spine? Well, it's pretty similar to the one in the lumbar spine. Flexion is okay. And then you have an equal limitation of side flexion and rotations, and also some limitation of extension. This is the full articular pattern. Remember, what's the diagnostic interpretation? Full articular pattern, arthrosis, arthritis. Any other combination that does not correspond with this, so any other possible combination, we call it automatically the partial articular pattern. And keep in mind that an internal derangement always presents itself as a partial articular pattern. Always. But okay, let's go back to the full articular pattern. If the patient has limitation, not too much pain, and a harder end feel, remember a harder end feel on rotations, extension, okay, normal for arthrosis. But if it's quite painful, then there are different options. Ankylosing spondylitis, rheumatoid arthritis, a recent fracture or a luxation, post-concussional syndrome, some bone disease, or a lesion high cervical. So there we have to do some differential diagnosis towards the future. Possibly I already mentioned that cervical disc protrusions are most common as from the age of 50, between 50 and 60 years old. Yeah? Excuse me. Yeah? Under the age of 30, they are not so frequent. What would be the general image of an internal derangement? Well, first of all, it depends on the size and it depends on the location. The more central an internal derangement, the more influence it has on your articular tests. Rotation, side flexions, extension, they could be more painful and more limited. The more lateral protrusion, the less influence on your articular test. Oh, that doesn't look too bad. Not too much limitation of movement. But at the end, some arm pain. That's not too bad. But at the end, some arm pain. So it looks better, but in fact, it is worse. Because the more lateral a protrusion, the more difficult to reduce. So when you talk about articular signs, you're going to have pain and or limitation of range of motion with active test, with passive neck test. Your resisted tests are negative. And apparently my television is doing something strange right now. Voila, it's solved, okay? There's always a little Murphy coming. So, pain, limitation of movements, active and passive test, positive, resisted neck test, negative, and of course you find a partial articular pattern. This is the image of an internal derangement. Yeah? When you have a lateral internal derangement with pressure on a nerve root, then you can also find some root signs. You can have some motor deficit, which you're going to, or sensory deficit, which you're going to discover also in your examination. Talking about motor deficit and sensory deficit, and perhaps a jerk which disappears. If you go back to the lumbar spine, one disc can compress two nerve roots at the same time. One disc can compress L4, L5 nerve root. One disc can compress L5, S1 nerve root. But we also saw that one disc cannot compress L3 and L4 at the same time. That was a red flag. In the cervical spine, it's very difficult for a disc to compress two nerve roots at the same time. So if you find biradicular symptoms or even biradicular deficit, this is a red flag. Certainly above the level of C5. Above the level of C5, this is anatomically not possible. Below the level of C5, anatomically it becomes possible that one disc is compressing two nerve roots at the same time, but it is unlikely. It is certainly not frequent. So my advice is, when you see biradicular symptoms, perhaps check also with medical imaging what is going on over there. Okay? So if a patient has unilateral root pain, has a lateral internal derangement, I told you earlier you expect the patient to be older than 35 years. Yeah, this is an empirical finding. And mostly in the story there was a shifting pain. Yeah? First he had neck-shoulder pain, pressure against dura. At a certain moment the protrusion is migrating, is shifting more in a lateral direction. No more contact against dura, but more contact against the nerve root. So this neck-shoulder pain disappears, and instead he gets some arm pain. So that's a pretty obvious story. So you expect monosegmental root pain, perhaps paresthesia, perhaps deficit. Lumbar spine, sciatica. Spontaneous evolution of sciatica takes 8 to 12 months. Once we are over half of the spontaneous evolution, the protrusion is not reducible anymore by manipulation, traction, exercise, whatever. Cervical spine, same mechanism, but faster. If you have a lateral protrusion with pressure against the nerve root, there is a spontaneous evolution in about 3 to 4 months. And also over half of this evolution, forget manipulation. So if the patient has 2 months of clear arm pain, no more neck shoulder pain, manipulation will not function anymore. Just stick to prophylactic measures and reassure the patient, don't worry, it's going to be okay, just a little bit patience. Yeah? You find some extra tests when it comes to root compression. For instance, Sperling's test, head compression in homolateral side flexion or compression in rotation, which produces radicular symptoms, arm pain. We already saw that in our basic examination. What did we do? Remember? Passive extension, passive rotations, passive side flexions. It's quite possible that one of those tests or more of those tests produce arm pain. Okay, no problem. This is a nice one, shoulder abduction sign. Sometimes patient says, well, I lie down in bed, I'm uncomfortable, my arm hurts. Yeah? And when I put my arm like this, it's better. And I put my arm like that, it's worse. This is better. Probably in this position they have less compression over there. Yeah? Could be an interesting element from the history. Or you build in cervical traction. And under traction, the patient immediately says, ooh, my arm pain gets better. My arm pain centralizes. You release the traction, bang, arm pain again. Traction, less arm pain. Okay, that's obvious. Yeah. Of course, in our profession, many other tests are described, specific nervous tension tests. But the problem with many of those tests, they have a very poor sensitivity, except for the upper limb tension test, but those ones have a very low specificity. So they will be positive in many patients without root problems. So again, I would like to advise you not to exaggerate with all that kind of nervous testing. Ask yourself the question, what's the purpose? Do I become wiser when I do those tests? Is that going to influence my diagnosis? Well, most likely not, because those tests are also aspecific tests and also have an influence on a number of other structures. So those upper limb nervous tension tests, they're not going to help me to make a distinction between carpal tunnel, cubital tunnel, thoracic outlet and cervical nerve root. No. And that's the problem. But okay, problem, that's not a problem for me. That makes life easier. I just don't have to do those tests. Okay, I'm talking about testing. I'm not talking about nervous mobilization as a treatment. That's another chapter. But from the diagnostic perspective, from the testing perspective, well, we don't integrate that in our standard examination because the added value is, let's say, moderate. Yeah? Again, be aware of multi-segmental paresthesia. Yeah? The patient who does a neck flexion and who produces paresthesia in both hands or both feet, perhaps in combination with some of those things over here, possibly spinal cord compression. Spinal cord compression could be asymptomatic, but it can change like that. It could change very rapidly. So if you find elements that go in that direction, and if the patient has an internal derangement, well, certain manipulation techniques are going to be absolutely forbidden. Certain other techniques are more safe. So, moral of the story, as long as there are no contraindications, disc protrusions should be reduced at once. This has a preventive value in that perspective, that by reducing it as soon as possible, possibly you avoid future complications. But let me explain that in another way. Let's imagine that a patient has a cervical disc protrusion. Yeah? And let's imagine it's the posterocentral protrusion. So this pressure takes place through the longitudinal ligament, the posterior longitudinal ligament. And what could be the problem now, if a patient has a very beautiful posterocentral internal derangement and the patient doesn't get mobilization, so we don't reduce the protrusion, the patient gets, let's say, immobilization. What could happen after some time, that thanks to this posterior derangement, you get too much tension in the posterior longitudinal ligament and some periost can be loosened, and of course periost, or the bone grows in the direction of the periost, and then you could get, after some time, you could get two fantastic osteophytes. So those osteophytes are the result of a non-reduced posterocentral disc protrusion. That shouldn't be a big problem. Mostly that's not a problem. But towards the future, that could become a problem, because let's imagine that an osteophyte is growing in the direction of the spinal cord, or an osteophyte is growing in the direction of a nerve root. Then after some time you could get serious compression and serious complications. So what is the moral of the story? If somebody has a posterocentral internal derangement cervical spine, and if there are no contraindications, we should do our best to reduce this as soon as possible. And then you're going to avoid overstretch of the longitudinal ligament, and you're going to avoid the formation of osteophytes.